All right, good evening, everybody. We wanted to welcome you all to the lumbar spinal stenosis disease and diagnosis and management webinar. We've been working on this webinar for quite some time, and we have an amazing webinar set up for you guys today with incredible faculty who've agreed to support us and share their expertise. As you all know, our patients are coming in with more and more difficult diseases, and at the same time, some of these folks aren't normally, the traditional surgical candidates that need the day-to-day spinal surgeries. And so as a result, we have novel technologies that we can offer them. And this is why we wanted to have this discussion. So again, I'm Dr. Ryan Budwani, one of the co-chairs of the Young Innovators at ASPN.
And my name is Nasser Khatri. I am another one of the co-chairs at ASPN Young Innovators, and I am a pain physician out in Michigan.
Perfect. Sir, you want to go through the agenda real quick?
Yeah, I think we have a pretty exciting lineup today. And really, the key for today is talking about lumbar spinal stenosis, which is a, condition that a lot of our patients, probably the majority of our patients who show up to our practices, suffer from in terms of the diagnosis and management. As Dr. Budwani had just alluded to earlier, there's been a lot of big kind of changes with regards to the management of this condition, really within the past 5 to 10 years. And we're going to go over, the kind of in general, we're going to talk about minimally invasive spine, interventional pain, and spine surgery. We're going to touch a bit about, training the interventional spine physician. Then really, we're going to go through kind of a history and case presentation, anatomy and image review, a treatment algorithm for patients who have lumbar spinal stenosis. We're going to do a case review panel discussion as well. And then finally, we're going to end it off with coding and approval, and talk, because I think that's always such a key part of our of when we, are offering patients therapies. And all of that's going to be for the CME portion of this talk, which is an hour long or so. We're then going to move on to the non-CME discussion. And specifically, while there are tons of treatment options available for patients for the management of lumbar spinal stenosis, we're really going to, have this kind of session focus more so on posterior lateral arthrodesis of the lumbar spine, specifically the Minuteman procedure. And we really want to thank Spinal Simplicity for their sponsorship of tonight's webinar for the non-CME portion.
All right, so thank you, Nasir. We're going to get started today. So really the first panel is the truly incredible people in the industry. One is Dr. Tim Deere, who I have the pleasure and the privilege to work with every day. As you know, the spinal disease process itself and what we're able to offer our patients, it's really at a crossroads. It's no longer chronic pain management, it's really minimally invasive spine and interventional spine and chronic pain all merged together. So we have two legends, one is Dr. Tim Deere and the other one is Dr. Stephen Hochschuler that, I had the privilege of meeting at one of these training events that was sponsored by Spinal Simplicity. He himself is one of the legends in interventional spine as a spine surgeon. And he's really an asset to the field because he sees what the potential in the future is when we collaborate. Because at the end, if we collaborate, it's our patients that win. And that is why we're here today. So with that, I'll hand it off to Dr. Tim Deere and looking forward to seeing Dr. Stephen Hochschuler in a second when he joins on.
Well, thanks a lot, Ryan. I think, we are seeing evolution here, and I think Dr. Hochschuler is going to be joining me in a moment. And we're really seeing evolution both of the fields, but also the number of patients with lumbar spinal stenosis. And the reason really is the aging of the population. And we also see a correlation between the number of spine surgeons and the market size. So Stephen, if you can join me, it'd be great. But you see these numbers here to your left, and you see the number of people who are aging. 65 plus population by 2034 is estimated to be 77 million people. So in the US, so that's a large chunk of our population when you think about 340 million people in the country. So there's a correlation there. And I think what we're seeing there, and again, I hope Dr. Hochschuler joins me in a moment, but we're seeing a lot of options we have in our field. And, I think one of the discussions tonight is going to be training of physicians to do these procedures. And for example, we talked about, there's Dr. Hochschuler now, talk about posterior lateral arthrodesis and safety and efficacy. We're really going to think about how we can do that in the proper way and who the patient is, the selection. Those are all things we hope to see tonight. You can have spinal cord stimulation, which we've been doing for a while. And then a lot of these people have, a combination of comorbidities, including SI joint disease, which also needs to be treated. Hello, Dr. Hochschuler, how are you tonight?
I'm terrific. Sorry for the trouble on this end, but I've heard everything.
Okay, well, maybe give some of your initial thoughts here as we go through these slides before we on this first panel. What are some of your initial thoughts?
Well, just overall, first of all, I thrive on energy. And I don't think there's anybody in the Young Tigers group that has more energy than you, Dr. Deere. And I was like you 50 years ago. So even though I look younger, I am not. Overall, I think that you need leaders who really lead, take risk, are willing to see where the puck's going, not a Me Too organization. And I'm thrilled to be involved because building Texas back, I always looked at what's next, not what already has been. And as a sideline, just to tell you, years ago, nobody believed there was such a thing as degenerative disc disease, herniated disc, or even the idea of spinal stenosis. It took years for people to accept those things existed. I'm handing it back to you, and any questions. I would like to comment on the role.
Well, I want to go back to the previous slide, right? Could you guys go back to the previous slide? I want your comments on this growing number of surgeons and diagnoses. What's your thoughts on that?
Well, I think two things. Number one, the population is growing. As you mentioned a minute ago, we're 340 million. I remembered when it was 250 million. We're growing quickly. The aging of the population is incredible, even though now we're not living as long as we did in past generation. Don't ask me why, but we're not. There are probably a lot of reasons, but the older population is growing. They're going to need care. I personally have had 2 spine operations in my life, and like Dr. Deere, I'm a very active athlete. And I wanted the second one because I couldn't play sports anymore. But I'm back. I'm in the gym 6 days a week.
Now that's phenomenal. And I think that's the other thing we're seeing. The reason minimally invasive spine is growing so much is people want to have a smaller, less invasive surgery so they can stay active. And many times it's earlier. So our goal of this first discussion was to talk a little bit about the problem. We know stenosis is growing. We know the number of spine surgeons has increased, and we know the number of interventional pain physicians has increased dramatically, and the number of patients needing treated has really increased dramatically. So I think one of the things, and again, I think in October, we'll be together in July down in Miami, but October, Dr. Hochschuler is going to be one of the co-chairs of our collaboration council. And one of the things we're going to look at is how can we partner, and so we refer to each other. And again, here in West Virginia, Dr. Budwine and I are very fortunate. We have a great relationship with our spine surgeons, and they'll refer to us someone who maybe isn't quite as severe enough for a bigger surgery, someone who's older and sicker and doesn't want a larger surgery. And we refer to them patients who need a bigger surgery than what we can offer. So there's that referral situation. Let's cover that first. Stephen, what's your thoughts on that collaborative referral? What have you learned about that over your many years leading Texas back?
Well, first of all, as I said, I always look at what's next. And just like in the cardiovascular and interventional cardiologists, I lived through all of that. And all I could tell you is the smart guys were not involved in a turf battle. They looked for what was next, and little did they know interventionalists were going to be king of the mountain. And if they worked together and referred as you described, it was the perfect setting. Now, what's most important for you folks and for me was always the patient. It is not my turf. It's not how good I am or how bad I am. It's really the patient should be in the center of the universe. Then you decide who's the best person to treat that patient. So we had it one time as an example, and I lost people in our organization over it. We started outpatient myelography. People are hardly doing myelograms anymore. I lost 3 nurses, malpractice. We also brought in 4 chiropractors, world-renowned guys. Why? 30% of pain people don't want to see a surgeon. They'd rather see an interventionalist. The last thing they want to see is a surgeon. And probably before anybody, they'd like to see a chiropractor with no needles. So everything is evolving, and our eye should be on the patient. What is the best treatment for the patient? When we started, there were no real interventionalists. we taught the interventionalists to do epidurals, to do facet blocks, to do rhizotomies, all of that. Now, few surgeons do any of that. In fact, you guys do the dorsal column stimulators, which is much more potential danger than doing minimally invasive spine surgery. Yet they're fighting you, they being orthopedic and neuro spine guys. They're crazy. If you can do it well and you've had the right training, and one of the things I think you're going to get into later this afternoon or this evening, depending where you live, is what I heard Dr. Deere say. You should have specialized training after your regular training to learn to do the procedures safely.
Yeah, Stephen, I think I hope I know a lot of people watch this on the recording more so than live because a lot of people like to watch it on their own time on the ASPN website and the YouTube channel. But I will say a few things. Your words of wisdom are so wonderful, and I think that patient-centric model is the way to go. And a couple of things about that on this slide here we see, a lot of people have talked about a 2-year fellowship. I don't think many fellows want to do 2 years of fellowship. I mean, and if you stay in the same fellowship for 2 years, you're not going to learn any more in the second year than you learn in the first. So I think ASPN is going to move towards, and we really have a steering committee we're establishing now to look at those who want to be more minimally invasive to do a post-fellowship. They do their fellowship and then do some sort of hybrid program where they are part-time attending and making a larger salary and part-time being hands-on trained. And a good example, Dr. Badwani has done literally hundreds of advanced procedures and has really done a wonderful job. And he really, scrubbed in a lot with myself and Dr. Kim. So, and now is certainly an expert on his own right, can teach anyone how to do those procedures. And then I think the second thing is, who should do what, that patient selection. Well, that only arrives, in my opinion, if you collaborate together. That's how you decide who should do what. If you're an interventional pain person over here in a vacuum and a surgeon, neurospinal surgeon in a vacuum, you'll make mistakes on that selection because there'll be times where I might be better for the person. There'll be times where you and your colleagues may be better. And unless you talk to each other, you'll never figure that out. So that's my takeaways from what you just said, which I thought was wonderful. So I think that's going to take us. Let's let Dr. Schuler and myself conclude our thoughts here. So I'll summarize, and then Stephen, you give us your final thoughts here. I think what we talked about was there's a growing population of need. There's an unmet clinical need for more care in these patients. People want to stay more active. They want to do more. They don't want to be in a chair at 75 and not doing anything. They want to still be out walking on trails and running and going to the pool. And so we have a real responsibility as a group to do that. And we also learn that we have to collaborate to make that happen. And by doing so, we have to make sure people are properly trained. So that's my takeaways from our first discussion. Stephen, you get the final word, and we'll go back to Dr. Badwani and Dr. Khatri.
Hey, Dr. Miller, I want to interrupt you just for 1 second, okay? Because I really want to pick your brain on this. Everything I agree with, what you said today, but it's really about building bridges to a better healthcare, right? And that's kind of our theme for our upcoming meeting as well in July. And so you as a surgeon, from the surgeon's eyes, you've seen, you've helped and you've seen the progress. And you talked about, especially, the cardiovascular surgeons that did, they opened up a chest and they took care of that. And then you had the interventional cardiologists, and you've seen that evolution. And so as a surgeon, if we're trying to reach out to some surgical colleagues that may not be friendly or may not understand everything that we can offer, what would be your quick, tips, to us physicians here that, may have to try to figure out how to establish that relationship? Because again, like you said, you have decades and decades of experience in building this. So if you could guide us there, I think that would be really helpful.
Two things I'd say. First, to just address what Dr. Deere said a moment ago, I think on your steering committee, you should have 1 or 2 surgeons, or maybe more, who are friendly, who see the future, and who help set up what you're talking about in terms of post-residency training. The second thing, in terms of what you just said, Ryan, is, sugar is a lot better than a whip. And what I've seen happen in Texas, and I've been involved from the beginning, I used to sit on the Texas Work Comp Commission. I volunteered for everything, as you guys are doing, and worked with Washington, worked with this and that. The key is stay involved. Then ask a surgeon to go out for dinner. A guy who you think is friendly. You don't want to take the meanest son of a bitch in the world first. Take a guy you think is friendly, take him out to a great dinner and sit and have a drink or two if you drink, relax. And the conversation will evolve.
Great advice. Great advice.
Thank you guys for joining us. Really appreciate the advice.
Thanks for having us. You guys have a great rest of the session.
Ditto.
So, that was a great session on minimally invasive spine, interventional pain, spine surgery, kind of the evolution of, pain management. So who better to talk to us about training the interventional spine physician than the guy who trained me, Dr. Syed, and then of course, Dr. Falowski, who's of course, taught me so much about DRG simulation, about burst DR simulation as well with SCS. And so, these gentlemen obviously need no introduction at all. But I'm really looking forward to hearing you guys kind of talking about, training the interventional spine physician.
Yeah, thanks for having us, Nasser and Ryan. I think it's really a pleasure to do this with Stephen. I think me and Stephen have together taught, hundreds of physicians over the last 10 years, and through society and industry training and webinars like this. So I think this is a really great topic. I think it's a problem that we're trying to figure out. We have to kind of figure this thing out on the run, because the previous slides show that, there's a lot of patients out there that need to be treated, and our surgical colleagues can't be burdened with doing all of these procedures. There's really just only so many of them. We know there's, neurosurgeons are a limited commodity, as well as orthopedic spine surgeons. So we have to figure out a way to do this safely and effectively. Stephen has always been, one of those friendly neurosurgeons who's embraced what our specialty can do, and kind of building those bridges. So Stephen, I'll let you have some words here as well.
Yeah, absolutely. And I think between the first session and what you just said, what it really explains it, that we don't have a clear answer yet to, what the best steps moving forward are. But I think we have an idea and a picture of that there is this idea of collaboration between spine surgeons and interventional pain that in prior years has not been embraced. And I think we're starting to realize that interventional pain physicians, their wheelhouse is starting to grow. The tools that they have in their armamentarium is starting to grow, and that there's a lot of spine surgeons out there who view it as a turf war, and that's just not the right way to look at it. And as you said, for the last 10 years, one of the things I'm very passionate about is the collaboration between interventional pain and spine surgeons, and finding where that overlap is, and realizing that there's so many patients that are either missing treatments, not getting treatments, and it's just a matter of patient selection on both sides, collaborating so we both learn where we overlap and being able to introduce these procedures. But true to our section that we have here, the idea though is, well, where is that overlap, and where does that armamentarium and toolhouse grow for interventional pain, where it's going to start overlapping with the spine physicians and spine surgeons? But what is the proper training for those interventional pain physicians that everyone feels comfortable with it?
Yeah, no doubt. And, I think when we think about, ideally, I think the plan is to, develop a more robust, accredited training programs through residency and fellowship. But you and I both know that's, a 10-year process at best, so what do we do today? And I think, since we have limited time, I think talking about how, we've developed these, these training courses that we've done, a lot of people will kind of, say, hey, you come for a weekend and you learn a therapy. That's probably not right. But, I think it depends on how you build it. We've been a part of some earlier in our careers that were kind of pretty terrible. But then later on, as these courses have evolved, and people like yourself and Jason Pope and me and Dr. Deere have been able to kind of help develop those kind of programs and curriculum, I think you can really provide a pretty robust training for people in the span of a weekend, but there has to be some follow-up and continuity to it. So what are kind of some of the things that you've seen where some of these kind of, these bioskill labs really kind of work, and when they don't work?
Yeah, I think that's spot on, Dawood, because when you look at what we actually have for training right now, and it says it spot on the slide right there, either, a company can come out locally, train you in 2 hours in your facility, and then take you out to dinner to talk about patient selection, or this idea of regional programs, which are a little bit longer, maybe a day long, bring in your whole group, talk about the therapy and patient selection, get hands on. And then we have national programs, which one of the things I love about national programs is usually the companies bring in premier faculty. It's usually at least a 2-day program where you get to have a lot of hands-on, a lot of lectures, a lot of talk on patient selection. And I think there's, as you come out of fellowship, one thing we learned from ACGME accredited fellowships is that there's a wide variability in the procedures that you do, whether you do a lot of spinal cord stimulation or not, or interventional type procedures. And for some physicians, once you get good at these new advanced procedures, maybe doing a regional course or just something local in an evening is enough to just learn the new procedure. But I think there's also a surgical skill set that comes with these procedures. And I think Tim said it best on the first session that we're going to have to look at ways where it may be the fellowship, plus something else while you're already in practice. And I think as we start training more of these procedures, you get better and better at them so that you can learn more, the new ones that come out. And I think that honestly, like Tim Deere, Jason Pope, yourself, myself, like we've seen all these new procedures unfold and we've become a part of them ever since the beginning. But what we're also starting to realize is new procedures are just continuing to come and that armamentarium is continuing to grow. And I think that's where there has to be a portion of it that it's not even just a skill set with your hands, it's what you actually understand of the therapy and the education. And some of that you don't learn in a weekend course. And I think that's why Tim said it best, that we're going to have something plus, in addition to a fellowship.
Yeah, and I mean, I think you make a lot of good points, and I think the silver lining is that it gets easier for people to add on these layers of new techniques when they already have kind of a base. Again, I think when someone learned one type of interspinous fusion, or like when the Vertiflex procedure came out, to add more of the fusion type interspinous devices wasn't such a large leap. I don't think if people in the interventional pain community really had that basis of doing kind of interspinous distraction without fusing it, it was pretty intimidating. I remember, because the Spinal Simplicity team is a local team here in Kansas City, and I remember looking at that. They were kind of trying to develop that before kind of the non-fusion devices came out, and it was very intimidating to interventional pain doc. Like, whoa, this is way too much, way outside of my wheelhouse. Fast forward 5 or 6 years and we had some more experience and we've been trained on these types of techniques, it wasn't as large of a leap. So I think, I think the evolution is good. I think, the more that we learn, the easier it is to add more things. So those are kind of my closing thoughts, and I'll let Ryan and Nasser if they have a couple questions for us.
Thank you guys both. I think that was an excellent discussion. So, the question I have, and this is especially for, Dr. Pawlowski. So you're the spine surgeon, who is really in a different world, right? You do more functional medicine, and then you work with, all these crazy interventional pain doctors, right, who are really leading the way. And so when you go to your society meetings, do you see that there's a barrier for folks to, look at what we're doing and say, hey, well, let's collaborate rather than, build a wall? I mean, that's one. And then the second thing is that I don't, in my opinion, right, ASPN is not just about pain doctors, right? It's not about interventional spine doctors only. It's about that collaboration. So what would it take for us to train some of those interventional or functional surgeons like yourself in our realm, in our wheelhouse, so that maybe when they, go and do that epidural, it's to the same standard or to the same level that we're expecting. Vice versa, that when we're doing the same type of procedures, it's to the same standard. Can you just comment a little bit on that, please?
Yeah, absolutely. I can tell you, I'm president of the pain section for the neurosurgery societies, the AANS and the CNS, which are the two big national neurosurgical societies. And I can tell you, it's split. We collaborate with the pain section. The spine section of neurosurgery as well, and it's very much split on how the surgeons feel about interventional pain, doing these procedures, and some of them view it as an encroachment, while some of them are starting to see the writing on the wall in the future that these are minimally invasive procedures that the spine surgeons never embraced, and now they've gotten better, the technology, the innovation. So it's about half and half when I discuss it with the spine surgeons. But I can tell you, and the answer to your second question is, the answer to both sides of that equation is they need to see that the interventional pain space is not only embracing these therapies, but has proper patient selection, but even more so like surgical technique. And you have to change your mindset, as now these procedures are extremely safe and extremely effective. But one of the things that I learned very early on in my residency is, spine surgery has higher complication rates, even though they may be small complications or questions. We get phone calls 10% of the time on every single patient. I can't imagine that an interventional pain physician would tolerate getting 10% of phone calls on epidural steroid injections. So you have to like change the mindset in the sense that it's not that things are going to go wrong or there's major things that are going to go wrong, but I think the surgeons just want to know that you're embracing what can happen with patients, what patients are going to call about. They may have more post-op pain than you're used to with like needle injections or even RFAs. And that you want to take care of those patients. I think that's the thing that they look for. And actually, that's the thing that I asked from interventional pain is, embrace these therapies, but also embrace the patients and everything that comes with it.
Excellent. And then Dr. Syed, I had a question for you. So, I think that, we talked about that we need to set a standard, right? We've not really developed that. But my question is, say you get great training, like, Nasir did, with you, and then you go to a facility that's not offering these type of procedures, right? Or they're offering something different. And you've been trained in it. How do you go and like advocate to keep those skills sharp and to make sure that, if you believe this is the right therapy, you've been trained in it to actually bring that on board? Because I feel like, in some situations, a variety training offers exposure to minimally invasive spine, and then a lot of training is just traditional chronic pain management. And so we're trying to figure out how to, solve that problem. But if you're trained, how do you actually go and advocate to get that technology available to your patients?
Yeah, that's a really great question, and it's a struggle for a lot of folks. And I think it's multifaceted. It depends on kind of what setting you're practicing in. I think probably just some basic kind of recommendation is always try to kind of go to bat for things that are grounded in solid evidence, especially if you're going to do something that in your new institution or hospital is something that typically wasn't done by your specialty. So if you pull out something that really has no evidence, no data, it's just new to the market, you're going to have a big struggle. Now, if you kind of vouch for something that has good solid evidence for it, has a good track record, a low complication rate, you're going to have better success. So kind of get your foot in the door with some of these other procedures that have been a little bit more well validated nationally. Don't try to do the most aggressive and the newest thing right away, because you're likely going to get shut down. And if you do somehow get it through and you have a complication, then that's kind of it for you. So I think start with something that's, reasonable. Talk to the key stakeholders in that institution and just get the conversation started. See what the roadblocks are. Sometimes you may find that the surgeons have, or the other specialists may have no problem with it. It could be a purely financial thing, or how the institution's set up. So you have to figure out what those barriers are, and then you have to kind of figure out how you're going to knock those down. But I think aim low when you start with one thing. Set a good reputation for yourself. Do really good basic medicine when you get there. Don't try to throw like 100 new procedures into the door right and they're going, who is this guy or girl? Is she a cowboy or a cowgirl that's going to do stuff? Do the basic stuff first, and then give it 6 months to a year, and then really start to bring those things in.
Excellent. Thank you guys for joining us. Really appreciate the feedback.
Thank you.
Thanks. Great job, guys.
Perfect. So for this section, Dr. Bovene is going to really march us through figuring out how do we go about looking at these patients, really figuring out what the right patient is, and talking a little bit about that patient and what that patient looks like. So I'm going to leave it off to him because that's people to guide us through.
Thanks, Ryan. Yeah, I mean, it's been teed up pretty well today. There's been such an evolution of the treatment algorithm that we have as interventional pain physicians. There's been such a change in the treating physicians, the techniques that we have available to us, the surgical tools that we have, and just an advancement in the last 10 years since I finished fellowship, and everybody's starting to look at their own MRIs, and I think that's amazing. It's something I jumped on early on in my career, did all these courses going to NASC conferences, doing the 5-hour pre-course in radiology, trying to do every elective because I knew this is what I wanted to go into. And unfortunately, my fellowship, I was not taught any radiology, so I'm glad I did that. And now I'm glad we're getting more and more of that, and the great Doug Beal is going to go on after me to talk about some of the basics of that. But what we're seeing now that we're treating this, you could go to the next slide, is not only the evolution of these techniques, but also it's repeating itself, as Dr. Hochschuler had said. They saw it in cardiothoracic surgery, whereas traditionally those with coronary artery disease, they had to have the open surgery, split the chest open by the cardiothoracic surgeon, doing coronary artery bypass grafts. Now it's more percutaneous intervention through the vasculature by an interventional cardiologist placing a bare metal or a drug-eluting stent. it's kind of that same thing. Instead of the traditional open laminectomy plus or minus a fusion, it's been these advanced interventionalists. It's not just the pain doctors, but now kind of a minimally invasive spine physician, if you will, that can do all these other advanced procedures, not just the epidural injections. There was the mild procedure, the Vertiflex, as Dr. Syed had mentioned, and all these, interspinous procedures that we're doing as well. And we've already discussed the kyphos, and we know that it's already switched with the instead of the traditional lami paddle for the stimulator, we're seeing with the percutaneous and now SI joint fusion being even in office. That's minimally invasive in that regard. So traditionally what we're looking for with these patients are going to have, a large component of pain with standing and walking in the back, going across their legs, and they're usually going to get relief with forward flexion or sitting. You're going to have that classic shopping cart sign. So again, correlating that with our imaging, and we're really going to have Doug Beal go into that a little bit later. But our classic stenosis patients, if it's more central canal stenosis, you're going to have more vague pattern. It might be the entire back of the leg. It's going to be more just vague. We're going to most commonly see that at the L4-5 level more so than 3-4, more so than 5-1. If you start getting that lateral recess stenosis, which is the next case I'll present here, at the 4-5 level, you're going to get that descending L5 nerve root, and you might have more of a radicular pain, just like we would see with a neuroforaminal stenosis. But again, this is going to be more intermittent, going to come and go with that standing or with extension, and then feel better if they lean forward or sit typically. Sometimes it can worsen if they do have an unstable listhesis or slippage, because that could narrow the neuroforamen worse if it does worsen with flexion. So that's the caveat to that, improving with flexion. So most of these cases at the end, I would guess, are probably going to be our older patients, our older generation. And I've done this particular, lateral, posterior lateral arthrodesis on patients anywhere from 27 to 91 years old. And most are in that, 7th, 8th generation of life. But I want to present a different one. This was actually a 27-year-old young male that was injured in his time in service in the military, and he failed conservative care, undergoing physical therapy, chiropractic, every medication you could think of, epidural injections. Ultimately had a left L5S1 discectomy in July of 2020, had recurrent pain. So November of 2021, they went back and did an instrumented fusion at L5S1. He got a little bit better. We're still having bilateral L5 clauditory symptoms and had numbness, tingling in his toes. He underwent further physical therapy, more injections. This time we had seen him and we did these injections, and he was only getting very, very short-term relief. We get these x-ray films. We could see the initial one on the top left, the pre-op x-ray. We see his hardware is intact there. We see kind of this alligator sign, we call it, at the 4-5 level directly above his fusion. We see narrowing at that posterior disc space of 4-5, and it's much taller height-wise anteriorly at the 4-5 disc space. So we kind of call it an alligator sign, or it's that less than sign, or this angular instability. And there's also narrowing of the neuroforamen at that level compared to the more cephalid levels. AP, nothing out of the ordinary there. And with this particular patient, due to failure of conservative care, and this particular patient told me he actually had PTSD from his big surgery, and he did not want to go through that again at all. Didn't want to go see another surgeon. And with his MRI correlating with the bilateral L5, 4-5 lateral recess stenosis, we could see compressing the L5 nerve roots. He felt better with flexion. We saw that angular stability. We elected to kind of go around his hardware and do it at the adjacent segment with an L4, L5 Minuteman. This was a 12 millimeter implant with 1 cc of DBM loaded in and around the implant. And we see in those post-operative images in that one on the bottom left, we see there's more restoration of those end plates. It's more of an equal sign instead of that, alligator sign. We see great opening of that neuroforamen, and then we see a nice place in the AP. They're lined up and kind of keeping the spinous process from touching them. So he won't be able to go too far into extension. And if the full X-ray we see, we still have nice, sagittal balance there as well. We didn't throw him into kyphosis. So he's 6 months out now and still has great resolution of his symptoms. He's very, very happy man. And that's all I have for you. I don't know if you have any questions for me, Ryan, or Dr. Khatri.
Yeah, actually, so a couple of questions, Dr. Boganani. Obviously, excellent presentation. I think whenever we talk about these kind of newer modalities of treatment, really patient identification is the biggest thing. A couple questions. One is, you talked about angular instability, and that's something when we were talking about posterior lateral fusion, that's something that comes up a lot. Describe that a little bit in detail, if you can, for the audience, about what you're looking for specifically on the flexion extension films when you're talking about angular instability.
Yeah, so in addition to what we're looking for, so when we get those flexion extension films, we're looking in the lateral view, comparing neutral with extension and then flexion. Okay, so we're looking to make sure there's no slippage or spondylolisthesis, and if there is, we want to see if it's unstable. And then sometimes we don't see that, but what we will see is that when they extend backwards, we will see almost bone on bone of that posterior end plates. You know, compared to anteriorly, you see that huge opening, or we see that alligator's mouth opening wide, you know, to the anterior. And then when they go into flexion, then it kind of narrows out to the equal. So there's this angular instability where you get this big opening. You know, it doesn't have more of a kind of parallel end plates. You will. There's a lot of motion at that particular segment. That's more their angular instability. You know, we all know there's vertical instability we'll get just from that disc height collapse, and I'm sure some of the presentations at the end will go over that. But we'll lose that space in the neuroforamen as well. And these particular devices do a great job of that. If we look at the predicate data from other devices, we saw there was a 46% opening in the cross-sectional area of our lateral recess in the neuroforamen versus only about 11% improvement in the cross-sectional area in our central canal. So these devices do wonderful for those with neuroforaminal lateral recess stenosis. And then honestly, those levels are usually more easily identified because they'll have a more discrete radicular pattern as opposed to a vague, you know, it's my whole leg kind of presentation.
I guess another question that I would have is, and I know we're going to touch on this a little bit in the treatment algorithm, but where really would you kind of put posterior lateral fusion kind of on the treatment algorithm, for example, in your case, for this particular patient, or really just in general for patients, right?
Yeah. So if they failed 6 months of conservative care, you know, they have these claudatory symptoms or even radicular symptoms, there is an identifiable source. We can see there is neural compression on our MRI, or we don't necessarily see that because, you know, they're not fully into extension potentially. But typically when they're lying, you know, in the supine position, it's effectively like they're standing upright, you know, so you're going to typically see that. If there is that angular instability on the x-rays, if we have the vertical instability, it's, you know, where we see there's significant disc height collapse causing it. If we see facet effusions or facet gapping, you know, we know that there's at least micro instability causing that inflammation of those facet joints. We want to stabilize those, because what we see with that is it's going to lead to increased friction on the disc. It's going to wear it out a little faster, which is going to lead to more end plate spondylosis and more hypertrophy or facet joints, as well as ligamental flavum hypertrophy. So it's this chronic degenerative cascade where all that's going to combine to narrow our neuroforamen, our lateral recess, as well as the central canal. So we kind of slow that process and open it back up. So I like these particular procedures. If they fail physical therapy, it's been 6 months, they fail an epidural or two. If we see those facet effusions, if it's lateral recess or neuroforaminal stenosis, they get better with flexion. This is a home run. If it's more of the central canal stenosis and a lot of ligamental flavum hypertrophy, less so of the radicular, less lateral recess, maybe a ligament decompression, but sometimes they'll have both. So it's easier to do, you know, a mild procedure for ligamental flavum hypertrophy if you think that might be a component of it. Then if it's not enough, you go in there and do this afterwards. It's a little more challenging to get around this hardware. I've gone around with a mild around Vertiflex. This is a little wider implant, a little more challenging to get around, especially with a streamlined technique.
Awesome. Thank you, Dr. Bovenet. Appreciate it.
Certainly.
Next up, we have Dr. Jacob Fleming, who is currently trainee or in practice with Dr. Beal.
Yes, I'm Dr. Beal's fellow. I
Okay,
apologize.
awesome.
He had another obligation come up and asked me to take his place.
No
So
worries. Yeah, no, I can't think of someone better to kind of go over anatomy and image review than someone who's, you know, obviously, being trained by him, you know, sort of our resident expert, if you will, of ASPN, of, you know, anatomy imaging review, of course, as an interventional radiologist. You know, whenever I work with, you know, any trainee, like when we had residents come through in fellowship, or sometimes, you know, we would have, you know, kind of residents come through at my prior job, you know, I would always say that, or if I'm working with nurse practitioners also, actually, I always say, whoever I'm talking to, reviewing your own imaging is critical, you know. And I mean, I think back in the day of just epidurals and RFs, you could probably get away with maybe not looking at your own MRI. But I think now, especially when we're talking about these more advanced procedures, it's really critical that physicians are looking at their own imaging, whether that's plain films, flexion extension films, or if they're looking at MRI as well. So Dr. Fleming, go ahead and take it away. Give us a little review on anatomy and image review.
Absolutely. Thank you for those kind words, Dr. Khatri. I couldn't agree any more with the points that you made. And like Dr. Beal, I come from a radiology background, and so I'm very steeped in the imaging. And I will say, since beginning my interventional spine fellowship, my approach to imaging has changed quite significantly. So the vocabulary that I've learned and the reps that I had during residency are very helpful. But I think we gained so much through the clinical aspect. So, of course, all of you have had the pleasure of reading MRI reports, and there can be quite a bit of heterogeneity of just kind of how well things are described, assortment of the pertinent findings versus things that are not clinically pertinent. And so I agree with Dr. Khatri completely. It's crucially important that spine physicians become comfortable with reading their own MRIs. And so I'd like to share, Dr. Bobinette did a fantastic job already covering some of the things that I would be talking about. And so I'll just go over a few of the aspects of spinal stenosis imaging. And so, of course, the most basic imaging study that we tend to see is the lumbar spine radiograph. And as a radiology resident, I found these studies to be quite useless, honestly, compared to the information that you can get from MRI or CT. And I've really grown to appreciate the versatility of this study, both from giving you the global sense of both the coronal and sagittal alignment, and showing you dynamic potential for dynamic instability, angular instability as well, like Dr. Bobinette described. So it's very important that we take load-bearing X-rays, and especially if you have concern for instability. I wouldn't say this is a necessary study in all patients if they've already had an MRI, but it gives a lot of great information. And so, of course, between the flexion, neutral, and extension X-rays, we're looking for any significant change in a spondylolisthesis. Of course, even a stable spondylolisthesis that doesn't move can still cause symptoms due to stenosis, but these are two comorbid processes. So, of course, due to the biomechanics of the lumbar spine, L4-5 and L3-4 bear most of the flexion stress and are the most affected by lumbar spinal stenosis. L4-5 being the most common, as Dr. Bobinette alluded to. 2-3 and 5-1 tend to be relatively spared. It's not uncommon to see stenosis at 2-3 or even 1-2. But 5-1 is actually quite a bit of a rarity just due to the capaciousness of the canal down there. It does happen, and it's important to be able to look at these. And of course, the radiograph won't give you a great indication of the degree of spinal canal stenosis, if any, but gives you a great understanding of any sort of dynamic instability and the spondylolisthesis. And so looking at the MRI, really our workhorse for imaging in our spine care patients. And so we tend to think that the sagittal T2 or STIR tends to be the money sequence on this. And I would say that you can see quite a bit of the action from this. The axial is really kind of the one that will really tell you the degree of your stenosis, but it's very important to be able to look at the sagittal. This is sort of an analogous view to what we see on the lateral X-ray and what we're going to see on a lateral view under fluoroscopy. So this is something that makes a lot of sense to us and starts to give us a sense of what may be going on in terms of foraminal, lateral recess, and central stenosis. And here are some of the things that we'll commonly see here. Of course, most cases of spinal canal stenosis are related to the effects of degenerative spondylosis. And so we see broad-based disc bulge, also with height loss of the disc, worsening matters of foraminal stenosis especially. We see the narrowing of the spinal canal, of course, the ligamentum flavum hypertrophy, and facet arthrosis as well. And you'll see most commonly in most MRI reports that level by level, these are typically described in a very kind of eloquent fashion. And having been taught to dictate in that fashion and read and dictated many studies in that fashion, I have to say that I've stepped away from it quite a bit, because most of the description of how certain aspects are narrowed or effaced just aren't pertinent. And we'll kind of go into some of that. When you see something like this, in that you can clearly see that the canal is narrow. There's a bit of spondy at 4-5, and all the aspects of spondylosis are clearly contributing to it. And you will also see that the nerve roots become compressed, and you can see some redundancy of that as well. And so here's the axial shot. And I said before that this is really your truth slice when it comes to assessing the degree of spinal stenosis. And here we have an example of, I would call this moderate to severe or even severe spinal stenosis. And we'll get to some of the associated findings here. When it comes to grading the spinal stenosis, really the only thing that matters is how much fluid can you see at the level. And so you will see that different kind of grading criteria are used throughout MRI reports. The two that are most commonly used, even though they're not typically referred to by name, are the Lee, L-E-E, and Schizas classifications. Schizas, S-C-H-I-Z-A-S. And you can look these up on Radiopedia, and kind of goes through relatively easy to understand classification. If you have CSF all around the nerve roots, and the nerve roots are not clumped together in any way, at most that's a mild stenosis. As you go to a point where the fecal sac is compressed to the point that there is not a whole lot of intervening fluid, you're getting into the range of moderate. And when you have no fluid visible whatsoever, then you're definitely in the degree of severe or even extreme spinal stenosis. And so we can see in here, again, this is a nice example of, as I said, moderate to severe or even severe spinal stenosis, because we really can't see much of a CSF signal along with the nerve roots. These are all clumped together. And if we were to look at a sagittal, we would see the same, and we would see that there's redundancy of nerve roots basically from chronic stretching and just due to the nerve roots above being kind of compressed and tethered in a way. And so this is sort of a linguini sign on the MRI that you can see on the sagittal, but the axial will be your truth sequence. And of course, we also see some associated signs. Of course, facet hypertrophy being essentially ubiquitous among patients who have spondylosis, but especially any degree of spinal instability. As Dr. Beauvenet said, both facet effusions and facet gapping are very good indirect signs of some degree of instability, whether that's micro instability that could be symptomatic or something that would show up as a 3 millimeter or more translation on the radiographs. And so these are great things to look for when you have MRI, but not the FlexX yet. And I would describe facet gapping as being 4 millimeters or more. Otherwise, we just kind of describe these as effusions.
So, Dr. Fleming,
Yes, sir.
I'll sort of just ask if you could kind of summarize potentially really the most important, radiographic findings that you're really looking for when you're reviewing MRI or flexion extension imaging, for this spinal stenosis patient.
Absolutely. So I would say most of the time in our clinic, we are not having x-rays brought to us. And so we're typically starting with the MRI. And so a great place to start with is either T2 or STIR sagittal. Start in the midline and then scroll through to either side. Just have kind of a light gaze upon everything and see if any of the findings here on this slide are jumping out at you. Cauda equina compression, nerve redundancy with this kind of linguini appearance. And once you see those, you then take a look at the axial, go to the affected level, and you can very quickly say what degree of spinal stenosis is, and if there's associated findings such as facet effusions and gapping, they're indicative of instability as well. And of course, so stenosis and instability often go hand in hand, and that's where the interspinous fusion devices really have a role to play. But I would say that's generally become my approach, especially when I have a patient who's come to clinic and I have at least a decent idea of kind of what their pain pattern is. We have all our patients, I'm sure this is common practice among many others as well, that the patient has a pain diagram and kind of marks where their symptoms are. It can be a little bit questionable how accurate it is, but usually you can start to get, okay, is this maybe L4-5 or is it something higher that may be the level? Just starting with the sagittal, quick scroll through there. You can also evaluate the foramen and get an idea for that as well, and then take a look at the axial. And once you get this into the context of your patient's complaints, you're going to be able to pinpoint the source of it with pretty good accuracy. So as most of us may already be aware from having used or trained with an interspinous fusion device, which is the Minuteman currently in the U.S., it's intended for fixation and fusion of the TL and sacral spine. It attaches to the posterior spine, and the spine processes through locking plates, and intended for use with bone graft material for fusion. High hydroxyapatite coating aids in the fusion process, and so it instantly provides a degree of immobilization and stabilization. And so you'll often see your patient 2 weeks out from the placement of this, and they say, "Hey, I'm feeling absolutely better," and that's great. Some patients they don't have quite that quick response, and so important to understand it takes about 6 months for full fusion. And so we don't put a lot of hard restraints on these patients, but it's important for them to understand that this is more of a long-term process. We need to give it time to heal, but you should have a pretty good idea if they're going to be a responder right off the bat. And some very good research has shown that the fusion rate of this device is in the neighborhood of 93% or so. And so when these patients are well selected with the imaging and clinical criteria, they can do quite well.
Thanks, Dr. An excellent review of imaging. I know we could probably spend an entire lecture or two on that. So I appreciate it, man. Thank you so much. So next off, we're going to hand it off to Dr. Stevens, who's going to quickly kind of run us, through the treatment algorithm. Everybody's touched on it a little bit, but he's going to kind of go through his secret sauce of, how he identifies patients, especially to make sure and ensure that they have really good outcomes. Thank you.
Okay, thanks, Ryan. Well, I'm just sitting here just kind of super excited about what we're hearing. But what I'm not excited about is that Dr. Bovanet has already stolen almost my entire talk because you got such great prompting questions from our young moderator. So Dr. Bovanet, that was an awesome display of most of what my slides are going to say. I'll try to highlight a few things. I also want to thank the surgeons on the call. Obviously, having Stephen on the call is extremely important to this process. And I want to highlight something Dr. Falowski said that I thought was so key. And what I think he was trying to say is that when you start thinking about doing procedures like posterolateral arthrodesis, you need to start to think like a surgeon. That means you're going to have more complications. That means you're going to have more phone calls. That means you're going to have these different things happen. And so what I want to say is that means we're going to need to follow our patients more closely and confirm that they had a good fusion and confirm that their post-op care is going well. It's not just epidural and forget it. And so I love those points you made. And Dr. Hochschuler, of course, is one of my heroes as a Texas Back Institute, being in my local area and knowing of him for so long and being on webinars with Stephen. It was great to have him on. And just everybody did such a good job so far. I don't want to leave anybody out. But what I do want to do is kind of go through a little bit of what we were just talking about with Dr. Bovanet. But I was just flipping through LinkedIn just a minute before waiting for this to start. And our friend Corey Hunter is getting fired up about posting about things being denied. He was talking about how epidural injections now, if you had a epidural injection and it lasted for more than a year, if you come at it at the second year to try to get it approved again, the insurance he's dealing with is denying that. And I don't even understand the logic behind that. But what I do know is that in my practice, if patients are starting to have a less return on effect of an epidural steroid injection, maybe it's not lasting as many months as it used to, or maybe it's not being as effective as it was. Those are already people I'm starting to think about. So I've asked, I've already done the RICE and all the PT and then non-steroidals, which you want to make sure you mention if you have a peer-to-peer, because if you forget that non-steroidal they're taking, boy, they'll just continue to deny you. But if somebody's not getting the relief from the epidural injections any longer, they immediately start to move into a camp like this. But to be honest, I use my epidural injections as a diagnostic tool more than a treatment tool. I think most of us would agree that we know that we're not going to be able to keep most of our patients with spinal stenosis and with some of the other things that Chris talked about, the parametrial stenosis. We're not going to be able to keep them better by just doing epidurals alone any longer, especially with Medicare only allowing 2 per year. That doesn't really work with our algorithm. So if you're an algorithm-based practice, maybe you have nurse practitioners or PAs, and you want to start thinking about how do we funnel these patients to get them to the surgery OR setting, look at this. And so people that have had radiofrequency ablations and they continue to get relief, well, that's a reasonable treatment. And there is a little bit of overlap with those two patients because typically when you have a facet-mediated pain in the lumbar spine, they're going to get relief from flexion, and that is common to this. But the story is way different. We're going to talk about that in just a second. But as you're kind of thinking about how do we get to these patients, you've already gotten a lot of pearls from Tim and from Dawood and from both the Stevens. And so I'm just going to add to what these guys have already said. So when you look at this next slide, we talk about if you have that algorithm set up, and I think the next slide is the White and Punjabi kind of calculation slide. And if you're looking at that and you are trying to figure out, does a patient have any form of instability, those are the things you can count on, because you can look at how many points do they get for each of the indication. If this get to a score of more than 5, and it's a candidate for having a potential instability status. And so we need to start thinking about our patients not just as having a radiculopathy, but what is the source? Do they have stenosis? Do they have a level of instability? What is really going on at the core? And I think that's one thing that we've really started needing to think about. Let's stop right here. So if you look at this, again, Dr. Bobinette gave a great story here, but what I want to do for a second, I want to leave a few points in people's minds that you won't forget. So I want to ask you, where were you when the world stopped, not when the world stopped turning, where were you when you heard that you could have not discogenic back pain, but you could also have vertebrogenic back pain? Do you remember that moment where you had this aha moment and said, wow, that makes sense? And so now what happens, now let's play a little game of what you, like word association. So you see a MRI and you see modic changes, what do you think? Basivertebral nerve ablation. Well, that is the way we have been programmed now. That was not something we were taught in that fellowship, and maybe we needed that extra year of fellowship training that Tim and Dawood are suggesting, but we didn't learn that. It wasn't part of our training. So now we're having to open our minds and our eyes to different algorithms and some different paradigm shifts. And the new paradigm shift for you tonight is what's already been mentioned several times, and that is think AI. Think about angular instability. If you look at this picture here, what you'll notice is you've got an MRI that Dr. Fleming did a beautiful job. We'll let Doug know that you did a beautiful job, by the way. But when you look at that MRI, you're getting some of the picture. I think what you can see from that is that there is stenosis. You can see there's ligament flavum hypertrophy. You can see there's facet hypertrophy. But we don't know until we get the flexion and extension film what degree of either dynamic instability or angular instability or vertical instability there really is. And so I want to totally emphasize the group tonight. You don't have the full picture unless you get these flexion extension x-rays. And so I go to the OR with my MRIs, and both very well described by Dr. Fleming, your sagittal images and your axial image, but I also go with my flexion extension x-rays, and I'm looking for that angular instability. So for a while there, I will have to admit, I was looking at patients and going, how could they have neurogenic claudication? How could they have these symptoms? They don't have that bad of an MRI. There's not that much instability. And then when I learned this phrase and this new movement about angular instability, it all made sense, because these are our patients that show up with neurogenic claudication, and we wouldn't sometimes know that. You look in the flexion film, and the end plates of the inferior L4 and the superior L5 are in parallel. But then when you put them into extension, you get that alligator mouth or Pac-Man mouth. If you're, Ryan, if you're from my generation, that there was a game called Pac-Man. You may not have heard about it, but anyway, you should look it up sometime. It's called Atari. But the point is, that thing right there shows me that even if there's not a big slip, and yes, this helps a lot with peer-to-peer conversations if you need it, when you can tell somebody, yeah, they say there's not a big grade 1 spondy, maybe there's not, but there's angular instability, and the patient has neurogenic claudication symptoms. So when you see this Pac-Man mouth, this alligator mouth, whatever you want to call it, think AI. That's the key from my section of this talk. So we talked about this a little bit. This is available for you to get from all of your reps, and it's maybe if you have one of those practices where mainly the nurse practitioners, PAs, are doing most of the work of getting patients to the OR, this might help them. But we've already gotten a really good description tonight of what it looks like to have instability, and all of these things are scored out and give you points, and you have to have 5 or more points to prove that there's a level of instability that you should be thinking about. There's a couple of things we haven't really hit on. I want to hit on these real quick. So Chris talked about this, but that shopping cart sign. So when your patients walk in, if they're walking with a walker, if they're walking with a cane, you're already thinking that might be a candidate. How long can they stand before they have to sit? How, when they go to the grandkids' games, do they have to stop at every bench along the way just to get to the bleachers? Do the legs feel heavy when you stand too long? Does it get worse when you stand? Sometimes patients will even describe a little feeling of instability in their spine if you listen to them and let them talk long enough. And then what is the best position? Well, sitting down, leaning forward, kind of with their head between their legs, opening up that spinal canal is the most comfortable position. So what about this section here? Who are we looking for? Who are we excluding? The excluding people is a smaller list of people, but acute pars fractures are kind of a do not pass go, you got to stop here. But there's a lot of degenerative pars fractures out there, patients that have a degenerative spondy that had a pars fracture from years ago. And what you will find if you get a CT scan is that there's been some collision of the bone, and actually there's actually healing appearing on the CT scan. And if there is, sometimes those pars fractures, if they're old degenerative fractures, don't have to be ruled out. But I encourage you to get your flexion extension x-rays, and if you have a question about the status of the pars fracture, to get a CT scan. There's also people that have had their spinous processes removed. I had a patient drive in from Lubbock, which is 5 hours away, for a Metman the other day, and I picked up couldn't get a CT because they had a pacer. I picked up their CT scan and scrolled through the axial images, and there's something missing, right? There's something I can't hook onto. So I had to kind of let them know that they are no longer a candidate for that. If somebody has a scoliotic curvature of more than 25 degrees at the level you're treating, this doesn't mean if it's anywhere in their back, it's 25 degrees, but at the level you're treating, those people need to be ruled out. And then anybody who has over a grade 2 spondylolisthesis, those are ruled out. I think people have a degree of comfort in the grade 1 category, but grade 2 should be ruled out. I think I covered, even though some of those I answered before the slide came up. I think I got most of the information, but great discussion from everybody tonight. Great moderation. I'm glad I was able to be part of this with you guys. Thank you for inviting me.
Thank you for joining us. That was an excellent review of the algorithm. Appreciate it. Thank you.
Of course.
All right, Amol, it's all you, my friend.
All right. Yeah, thank you. Ryan, Nasser, great job. And I'm kind of honored to be here and presenting. And I guess what we're going to do now is have a little bit of fun. We're going to do kind of a rapid fire case panel discussion. We have Dr. Kristen Jarzambek, Dr. Katrina von Kreugenberg, and Dr. Ashley Bailey Klassen. They're going to go over cases. And I think this is really important because a lot of times this is the best way to learn. By seeing a case, seeing how it was done, seeing the decision making that was that occurred to come to the conclusions that they did. So let's just get right to it. And I think all three of them are going to present in succession. So go ahead and get started. Thank you. And it looks like Ashley is up first. So
I am sorry, I had to step out for half a second. The dog was going to comment on her section of this as well, so I had to make sure that stayed quiet in the background. So I'm going to go over really quickly kind of an interesting case. This was a 41-year-old female. So we've talked about that these procedures can cover all sorts of age groups. Dr. Deere mentioned earlier that for some instances, we're doing these in a lot younger patients or patients that don't want a big spine surgery. That was this patient to a T. So she was a 41-year-old female. We actually ended up doing her L2-3 level. So again, that's already been discussed tonight, that is one of the more rarer levels for us to do. But at that level, she did have some mild central, but mainly more moderate neuroforaminal stenosis on the outside. So one thing I kind of want to highlight on her pre-op flexion extension x-rays, which again, I agree with Dr. Stevens, this is something I take away every single time when I'm assessing these patients. If you'll notice, she actually has a little bit of retrolisthesis at 2-3 and a pretty good amount of anterior lipping at that disc. So kind of gave me an idea that it was that level to start looking at, though she's got degenerative changes kind of all the way up and down. She had been fighting with this pain and a lot of leg radicular pain, a lot of that neurogenic claudication that we see for about the last 3 years, and had kind of tried everything. One thing I want to highlight what Dr. Stevens mentioned. So how did I pick that level? Because when you look at that x-ray, she's got changes kind of all the way up and down, right? Diagnostic epidurals. So specifically, we were doing transforaminal epidurals individual days at those individual levels and finding out which alleviated the majority of her pain. And so that's how we kind of isolated back down to that 2-3 level, that was really what was bothering her. While the other levels look like they've got some stenosis there, 2-3 was the only one that had some dynamic listhesis. So that's why we elected to fix that one. She is about 2 years out now and is doing great. I will highlight my post-op x-ray for some reason was taken as a PA, not an AP. So we did actually come in from the left, as is most commonly done, but that's why that looks a little backwards on that image. One thing that I did love in her post-op x-rays though is how open that neuroforamen is at, or that neuroforamen is at L2-3, how well that stayed open. I do have another one where it's in flexion in another slide, but, or in another full studies, but the extension, because that's where she closed off in her pre-op stuff, I wanted to make sure I highlighted that here. When I'm looking at my x-rays on top of that angular instability that we've talked about tonight, another thing I keep an eye on is what do those neuroforamen look like? Do they change from flexion to extension? Because that's going to be something that causes those patients symptoms as they move down that cascade. So that's another highlight point I want to bring on tonight. With that, that's my case.
Excellent, great job. So we'll move on to the next one. So we'll go on to the next slide.
All right, so my case is about a 75-year-old retired gentleman. He had been retired about 10 years prior, and what a lot of people do is wait until they're retired to have big spine surgeries. And so because he had a lot of radicular pain, he ended up going, and some instability, he ended up with a TLIF, left-sided L5S1. And then when he presented to my office January of last year, he only complained of axial low back pain. And it had been going on for the past 6 years since his surgery. And so he was a little bit frustrated because he couldn't do as much as he wanted to because he had this pain whenever he would stand, walk, and twist. And so with no new MRI after his surgery, I wanted to see what his hardware looked like. So we ordered an MRI. And, you know, along with his physical exam, there was some cassette hypertrophy. And so it was decided to do radiofrequency ablation of his medial branches at the L2, L3, and L4 levels. He did great, 65% relief. And then a couple months later, he presents, and now all of a sudden he has neurogenic claudication symptoms. And he's complaining because he can't walk for more than 2 minutes, and he's getting super frustrated because he just wants to enjoy his retired life. And so now he's not really complaining about back pain with twisting. Now it's just like tiredness. And so, you know, review of the MRI showed that he did have, it was kind of complicated in terms of he had several levels that actually could have been treated. And actually with his flexion and extension film, he actually had more instability at his L4-5. And taking a lateral view and stuff like that, with it being my first case for the Minuteman procedure, with discussion with him, we decided that it would be an easier approach and he would still get relief because he had central stenosis. He also had lateral recess stenosis, as well as a minimal enterolisthesis at L3-4 as well. And so we did the procedure there. He followed up. He wanted to follow up because he was going out of town because he was hoping that it was going to work. He followed up a week afterwards instead of 2 weeks afterwards. And at that point, he was already getting 70% relief. He had no limit on his walking time. It was more physical exhaustion than leg tiredness. And so that was done in August of 2023. And since then, his facet arthropathy pain recurred. And so we did a repeat radiofrequency just this past January. And after follow-up, I'm supposed to see him tomorrow, actually, or Friday, and he canceled because he said he's doing great and he wanted to know if he could just push out his follow-up. So I thought that was wonderful. Just like, you know, the case before, there were so many things going on. One thing that I didn't mention, and you can kind of see in his fluoroscopic image, is that he also had complications higher up because he also had some levoscoliosis. So luckily it wasn't at the treatment level, so I didn't have to worry about the 25 degrees or anything like that. But it's nice to know that, you know, even retired attorneys at 75 years old that waited, you know, their whole career to have their big spine surgery, we can still help them with different types of interventions starting off, I didn't use epidurals for diagnostic purposes for this because he didn't have any radicular symptoms at that time, and it was all axial, and he did have, positive chem. So the levels that we did were L2, 3, and 4, and it was just interesting that the instrumentation level for the Minuteman was at L3, 4. So, it goes to show that, one inflammatory process does affect the other, especially with aging. I'm so sorry that my lateral isn't as good. There's too much air on that. I should have had them collimate, but you can see, well, I could see there, the end plates were a little bit more, you didn't have as much AI angular instability there.
Excellent, great job. And I think we'll move on to the next case presentation. So we can move on to the next slide. Thank you.
All right, hi everyone. My name's Kristen, I practice in Austin. I love talking about this patient. She was one of my absolute greatest success stories. I've been doing this procedure for about 2 years now. This particular case happened in March of last year. This is a 76-year-old female. She is extremely active. She walks every day. She loves playing with her grandkids. Has been a patient of our practice for quite some time now, probably about 5 or 6 years, but very traditional interventional candidate, had had multiple ablations with our practice, multiple ESIs, and over time had started to fail her epidural steroid injections in that she wasn't getting the prolonged relief that she was previously. We tried just about every other, conservative measure. She did the NSAIDs, she did the PT, continued to move down the algorithm. She had a mild procedure at L4-5 late 2022, which didn't really do anything to resolve her symptoms. And, on review of her imaging, it's a little hard to see on her pre-op extension x-ray, but she does have some of that angular instability. She has ligamentum flavum hypertrophy on her MRI, but I don't have that included on this slide. Her predominant issue is not central canal stenosis. Her predominant issue is L4-5 moderate foraminal stenosis and lateral recess narrowing. So she had very classic radicular pain. So after further discussion, offering her all of the options, she was a very clear-cut Minuteman candidate. She had a size 12 spacer placed at L4-5. When I saw her at her 2-week follow-up visit, she was ecstatic. She was like, this is the best I've ever felt. I haven't been able to walk more than half a mile without my legs hurting in, months, years now. And May 2023 was the last time I saw her, and the last I heard from her was her sending us a Christmas card to our practice because she was so happy, and we haven't seen her since. So she's doing really, really well with her after her procedure.
That's an excellent case. And, clearly patient outcomes and patient satisfaction is so important. Clearly, you treated this patient well. I suppose I do have a question on this particular case. Did you consider other surgical alternatives and options? I mean, there clearly are some that would be, say, more invasive and still accomplish the same thing. And specifically, did you refer to any second opinions or did you handle her case entirely on your own?
No, the patient had been she'd consulted with a spine surgeon, I think even maybe 2 spine surgeons prior to undergoing any of her more advanced procedures. Like I said, she'd had multiple epidurals, PT, for years prior to having a Minuteman done. She was pretty adamant about not wanting any kind of spine surgery. She's, again, very active, was trying to enjoy her retirement, enjoy her time with her grandkids. She just wasn't prepared to undergo any kind of recovery that would come with a more invasive spine surgery. After, very thorough discussion with her, and this wasn't a, decision that was made at the, during one office visit. This was kind of months in the making after her mild procedure failed, but she had really considered all the options, including spinal cord stimulation, and she just was not enthusiastic about the idea of having an implant, like an IPG. So she was more impressed about the thought of having something that would actually address the anatomic cause of her pain.
Great, thank you. And what, great job, everyone, on your case presentations, and I'll turn it back over to Ryan. Thank you so much.
Well, thank you guys. Those are really amazing cases. What it shows is just the diversity and the large application of the tools that we have. Because if you saw those cases that we discussed and everything else that the presenters throughout have mentioned tonight, it's that there isn't one set patient that is the best fit for this. This tool fits so many patients across the board. And like Ashley even said that, younger patients, they don't need a bigger surgery. They don't want a bigger surgery. and you don't want to burn a bridge. And so this is where this comes into a really big solution for them. But the struggle we run into is coding and getting it paid and getting it approved. And so there's nobody else I can think of better than Dr. Yash Nalvagan, who can kind of walk us through this. I know we're running a little bit behind tonight, but I appreciate everybody for the enthusiasm and keeping up with us. So Dr. Nalvagan, it's all yours.
Thanks, Ryan. Great. So obviously, some of the things that we have to consider when we're billing and coding is, one, what our diagnosis is. Two, whether or not the codes that we're choosing really line up with the procedure that we're performing. And three, whether or not we've done preoperative assessments and fulfilled all of the pre-procedure requirements to meet coverage determination. And so with the Minuteman procedure itself, there are three predominant indications. The first is degenerative disc disease, the second is lumbar stenosis, and the third is spondylolisthesis. And for a minimally invasive procedure like the Minuteman, it's actually quite impressive how little you can do and still achieve these successes that we've been hearing all evening. So when we look at billing and coding, what we're really talking about is what procedure is being performed. First, we look at 22612, which is actually arthrodesis posterior lateral technique for a single space, and additionally 22614 if there's a second level. The other components to the billing and coding include 22840, which specifically refers to posterior non-segmental instrumentation, and finally 20930, which is morselized allograft that's being used. The coding is separated into our physician or professional component, and then whether you're in an ASC or whether you're in a hospital, there's various reimbursements associated with the site of service that you're performing this in. It can only be performed in an ASC or a hospital and is not an office-based procedure. When we look at the codes themselves, we break them down, as I said, into three specific codes that can be used. But my recommendation is that you speak with your billers and coders to ensure that your notes, documentation, and pre-assessment all line up with the coding that you're performing. And with that, I'm going to hand it back to Ryan and Nasir.
Thanks, Yash. That was exciting stuff this late at night.
I know.
Bad, man, but thank you for sharing that, because without getting all those nitty-gritty things approved, we can't really help our patients. I really appreciate you.
Absolutely. Take care, guys.
So, the prior conversation with Dr. Nalvagan about coding and approval, I think it ties really well into this review of clinical evidence. And really the reason is because in order to be able to get a distinct CPT code, or even to just be associated with an existing CPT code, and of course to be able to get approval with insurance companies, one of the things that they really are looking for is evidence. And again, when I work with physicians, when I work with APPs, or really anyone, I always emphasize the importance of reviewing the literature and to really make sure that the therapies that we're offering patients are rooted in evidence. Just because something necessarily makes sense does not always mean that it's going to work, right? So there's a slide here for the Safe Clinical Studies timeline, and really what it highlights here is that Spinal Simplicity has really spent a lot of time, effort, and money in establishing strong clinical evidence supporting its therapy for patients who suffer from spinal stenosis. The first one came out in Q1 of 2022, and it was a podium presentation at SMISS. And really, it was just about a 360 fusion, right? So it was about the utilization of this therapy in a 360 fashion for lumbar fusion. In Q3 of 2023, really came out a real-world fusion outcome, and that was published in Journal of Pain Research. And specifically, what was done there was looking at the rates of actual fusion in patients who had this procedure done. There was also a posterior fixation study published in Curious in Q3 of 2023. And actually in the current quarter that we're in, there was a safety and efficacy study that was published in the Journal of Pain Research for this device. Now, in the future, we have more studies coming out looking at decompression and Minuteman and then comparing the two therapies. And that's been submitted to the Journal of Pain Research awaiting peer review. There's also the stability study and looking at functional outcomes, and that's going to be published hopefully by, towards the end of this year. And then the Illuminate study as well, looking at anatomical metrics and really, looking at, this device and this therapy from that standpoint. Some of the key things that I think are important to, highlight about these, these therapies is that, or about these studies, is that the lumbar spinal stenosis, the PLSA study in the Journal of Pain Research had 191 patients with a mean age of around 69 and an average BMI of 31. So when we start talking about the replicability of these outcomes in our patients, I think that fits the bill of a lot of the patients who we see in our practice, right? And they noted a 50% reduction in pain. And interestingly, also they had, and which is good, no infections, device malfunctions, or migration. So when we start looking both at safety and efficacy, clearly the study, was able to show it. There's also a prospective RCT, which is pending publication right now, looking at Minuteman patients and comparing VAS scores, ODI scores, walking distance, and sitting to standing reps at 12 months and 24 months. And so it's good to be able to see that long-term outcomes for patients here as well. Interestingly, and of course, this is pending publication, what we're going to find is that there's no device-related complications, no reoperations for either group, or time was significantly lower for the Minuteman patients as compared to traditional decompression. And some patients are 10 plus years out from Minuteman, and some of their data is going to be in there as well. There's a biomechanical study as well, looking at stability compared to facet and pedicle screws. And what it found was that the cadaveric study found that the compared to facet and pedicle screws, this Minuteman device was effective in maintaining foraminal distraction as compared to the facet and pedicle screws. Finally, there was the real world fusion outcomes, which I think was a widely cited study in which it found that about 64 out of 69 levels that were fused according to a radiographic study. So there was a 93% fusion rate. There were a total of 43 patients and an average of 459 days post-surgery. And the other good news is that there were no intraoperative spinous process fractures or device failures, and no patient was excluded from consideration in this study as well. I think that this is a relatively novel and new therapy. The amount of evidence is just going to continue to grow for this therapy. And I think given, despite the fact that it's a relatively nascent procedure, the fact that so much evidence does exist for it right now really is quite impressive. And I'm looking forward to Spinal Simplicity kind of, expending more of their resources into kind of building the research and the studies behind it. I always say, we started off this talk tonight. I'm going to let Dr. Badwani kind of take the show from here. But, one thing that I always say is that, we love talking about comparing ourselves to interventional cardiologists and cardiac surgeons and all of that. But the one thing that the cardiologists did really, really well, and that allowed them to be able to kind of take the throne over cardiac surgeons. And I have friends who are interventional cardiologists and cardiac surgeons, so I'm probably going to get flack tonight for saying this. But the big thing was that the interventional cardiologists, they really, really invested in good data, and they proved that they were effective in what they were doing. And that's why I'm such a big proponent of research in our field, because that's really the only way forward for us to be able to really, prove that what we're doing is best for patients and that it's effective and safe to do so. And Dr. Badwani, why don't you tell us about the procedural technique here?
Excellent. Well, Nasir, thank you so much. It's been said that, evidence is currency in our field, and, you did an excellent job explaining that. And one thing, that really impresses me about Spinal Simplicity is really their commitment to evidence, to quality and sound research. And I think that, all the studies that you mentioned and their outcomes that are going to be coming out in the next couple of years are going to solidify that this is one of the approaches that can help our patients. Now we have a really special procedure technique video that we wanted to share with you all. A lot of people have asked us, just to have something available, whether they wanted to watch prior to, after being trained, and then prior to an upcoming procedure, if it's been a while. So we kind of put this together, and the goal is that, I've been doing this procedure for about 3.5 years now. We've done hundreds of cases at the Spine and Nerve Centers in West Virginia with excellent outcomes. And so we're going to share this video with you. Once that's completed, we'll just have a couple closing comments, and then that'll complete everything for tonight. Thank you, guys.
Hello, I'm Dr. Ryan Badwani, and today we're going to talk about the posterior lateral arthrodesis procedure using the Minuteman technology from Spinal Simplicity. The first portion of this talk today is going through the single-use kit that we're working with. The advantage of this kit is that it's available every time you need it, every single time that the patient's ready for it. We start off with the guide pin. The guide pin is really, really important here because it allows us to actually go to the direction that we're looking for and to keep that track going through the entire procedure. The value of this guide pin is essential because, as you will see when we demonstrate it under Flora on the cadaver, is that it helps to not only facilitate the procedure itself, but it's a huge safety margin to make sure that you're exactly where you need to be for this implant. So you start off with dilator 1. Okay, dilator 1 is important because it's the first essential step in getting to where you need to go. After dilator 1, you'll insert dilator 2 and then dilator 3. Once dilator 3 has been inserted, you actually want to add on an extension. And the extension is going to be important because once you put that on, we will actually jump onto sleeve 1. Okay, once sleeve 1 is placed, then at that point, since you have the extension on, that's going to help facilitate the removal of every single dilator, but making sure that the pin stays in place. That's a key step that you want to remember. Once that pin is staying in place, you come back and you actually use this graduated tap. This graduated tap is actually designed with a lot of safety in mind, but also, if you can notice, and I'm not sure if you can see it on camera, but we'll see it on Flora later on, is that you see these little insertion marks here. These marks actually correspond to the different sizes, the 5 different sizes that are available to help our patients, okay? So those are the different sizes of the implant that we're going to be using. With the graduated tap, this is actually built in to help open up the space that we're looking to put the implant into and to separate the area. Once we've identified the correct implant that we're using, then at that point we actually use the inserter. So the implant is added onto the inserter, and then at that point we can actually make the final versions of the impact. All right, now I'm going to talk about the G5 implant and the sizes available and the benefit. So if you look right here how the wings are sticking out here, that's actually really important because of the large window that's available. That's where the DBM goes, and typically each implant holds about 1 cc of DBM. Now the unique thing about this G5 implant is that these wings, you can extend this while they're in the patient, but you can also retract them if you need to reposition them. That's a huge safety margin that's built in. Now if you look right here, right in front of me, there are 5 different sizes available. You start off from 8 millimeters and go up all the way to 16 millimeters. The colors also correspond to a unique safety feature that's built in. From 8 to 12, you actually go with the purple color right here, and that purple color is actually it's the smaller sleeve that we use. Once you want to go from the 14 to the 16, you end up with the green sleeves, and that's just to help actually you kind of keep those different sleeves apart, but it also shows that once you're going into that larger size, you have different tools slightly that are available. So since we've covered all the instrumentation, we're going to be transferring over to the cadaver here so we can demonstrate this procedure for you. All right, so this is the cadaver demonstration portion of this lab. And the main thing is that really initially starting off with identifying the appropriate landmarks. So the initial picture is going to be the AP picture. That's important because in our lab today, our goal is to put the implant in between L4 and L5. And so we start off with a radiopaque instrument that can help us identify that picture. And so as you can see on that instrumentation, I can also use the guide pin if you need something a little bit more radiopaque to kind of demonstrate that picture. And so that's kind of where we want for our insertion point for that spinal needle. The spinal needle is really important because, like we spoke about earlier, that spinal needle helps us to identify the area, and it's going to serve as a landmark until we can get the guide pin in place. Once we get to this point and we've identified the area, okay, we want to make sure that we've anesthetized the skin pretty well, okay? And most of these patients, they're either going to be in MAC anesthesia or in general anesthesia. Regardless, we want to make sure that at any point we've identified the landmarks, we've anesthetized the skin prior to penetrating it, and then we've identified the exact area that we need to be at. Once we've identified that with the spinal needle, we're going to go back and actually move to the lateral view. Now, one thing that I want to comment on is I also anesthetize the tract as well. So not only do I anesthetize the skin there, even though we're not making any kind of generalized cut up here, but we're trying to anesthetize the tract because it keeps the patient more comfortable. All right, perfect. So as you can see in the lateral view, the spinal needle is exactly where it needs to be, okay? You want to be in the about anterior 2/3 of that the view right there. And then at this point, you can actually use the guide pin to demonstrate where the next landmarks are. And these are critical because of patient safety. Picture? Picture. Perfect. So in this view, we're trying to demonstrate where the landmarks are. And you want to make sure that the anterior portion of your marking is at the facet line. Picture? Okay. Picture? Perfect. Picture? And then the second line you're going to make is the posterior line here. Picture? So the reason I'm making the posterior line on this cadaver is because typically when you're actually beginning the insertion portion, you want to make sure that your implant actually ends up between the anterior and the posterior line. Picture? So that would be X marks the spot. That's literally where your implant should end up. Now, before we demonstrate anything more, I just want to make a key comment here, that the facet line is where you want to make that most anterior line. That's a huge safety margin of this procedure. Everything posterior to that is a safe zone of where we can provide this procedure. Now, once we've identified that line, we know where we are, we can go back to the AP view. So in the AP view, this is very important. And what I would recommend is what I do in my patients is that I actually draw a line from where that spinal needle is all the way down to where the anterior and the posterior lines that I've drawn on the lateral view. Picture? And so the reason I draw that is because the way I think of this is as a runway. This is the way that we actually want to guide the guide wire as we're going from the lateral view. This is the pathway that the instruments are going to follow. All right, so as we've done that, now the next step in here is actually to make that incision. So we've made the incision, and the very first step at this point, right, is starting the guide pin down that incision. So as you can see on the x-ray there, you see that little dark point, that's actually our guide pin. And it's headed down that landing strip that we had created initially. And so the reason we're actually starting in the lateral position, this is very, very important. It's a huge safety margin for this procedure, okay? You want to make sure that you're staying posterior to that anterior line you've drawn, because that's the safe zone again for this procedure. So what I would recommend is that you continue this in the lateral view right here initially. Picture? Perfect. Picture? Okay. Now we know that we're in our safe zone. We go back to the AP view. So we've gone back to the AP view, and this is where we're going to be doing the remaining portion of the procedure. But again, I always recommend checking that lateral view because it allows us and gives us another security of that we are in the safe zone for that procedure. So at this point, we're going to begin by using dilator 1. Now, another tip here is that try to have your scrub tech, actually dip this in saline because it makes it a little bit easier to slide over the guide pin. Now we're in the AP view and I've inserted dilator 1. And as you can see, you can actually make out that dilator as we're going forward. And then you see that facet line there. That's kind of where you want to actually have this set. Picture? And so you can make it out where it's at. That one, our guide pin is stabilized. And two, the first dilator can be made out right next to where that facet line is. And that's where I would keep that first dilator. And then I would bring in the second dilator here. And just like in this pattern, we will continue forward. As you can see here, we have both our guide pin, our first dilator, and our second dilator exactly positioned where they need to be. So I'm going to use a third dilator at this point. And in some situations, you have to keep a little bit of pressure on here just to make sure that they don't get dislodged from where they've been before. So as you can see, all three of the dilators are there. We've already put on the extension. At this point, we're actually going to put on sleeve 1. So as you can see in this picture right here, okay, our guide pin is exactly where it needs to be. All the dilators can also be seen and they're where they need to be. And we've actually finalized our position with sleeve 1. So what I would recommend at this point is that put a lot of forward pressure on this sleeve 1 here, okay? And this forward pressure allows us to ensure that we remain in the position we need to be in as we're slowly taking out each and every dilator that we had put in. And remember, again, that typically I'll have like my scrub tech or somebody back here holding a little bit of pressure here so that we don't actually lose the positioning of the guide pin. So now we're going to use the graduated tap. And again, remember that this tap is going to help clear up that space and help to determine the size of the implant we'll be using. All right, now slowly just turning this clockwise as we're inching forward. So typically at this point, when you've kind of crossed over that line and you see the spinous processes, you can actually take out the guide pin because you no longer need it since you're already going down that trajectory. So as you can see, at this point, I've continued to apply that forward pressure to the sleeve just to keep it in place. And we've continued to accelerate forward with our graduated tap. Now, a comment I really want to make here is that if you can see, it looks like, from those halos, we are at a 12. But if there's a little bit of wiggle room and we move forward, you would be between a 12 and a 14. All right, so I'm slowly taking this tap out by removing it and rotating it in a counterclockwise way. So continuing to apply forward pressure to the sleeve here, we're going to use the inserter and rotate it in a clockwise way as we advance the implant forward. Picture. Okay, you can go live, please. Okay, right, stop there. Okay, again, as we advance forward, I just want to make sure that continue to apply this pressure. It's really key here because as we are going forward here, it's going to become very tight and you don't want to lose the channel that you have created. So to deploy the wings, all you do is you just come here and you apply a little bit of forward pressure on this back knob. Picture. 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 Perfect. Picture. There we go. Now, one thing to remember, right, before we move lateral, just to confirm our wing placement, is that by stabilizing the instrumentation here, it allows us to actually make sure that the wings have remained deployed the way we want them to. And we're actually applying a little bit of backwards pressure on the instrumentation. Now, typically in this, if you can get a little bit of wig-wag, you can see the wing line. And you can see that you're keeping the channels on here, the wing reference line level. You can barely make it out at the tip. You can make out the left lower tip of the wing there, but if we can apply a little bit of wig-wag on the x-ray, we may be able to get a little bit better view. All right, so as you can see, like we talked about, if you can apply a little bit of wig-wag on the x-ray, you can see the location of that bottom wing, and that's really important. So just for demonstration purposes, because we've not tightened down anything yet, if we needed to, we can still rotate. Picture? And so I like the location of the wings right there. So at this point, I'm confident that the wing placement is exactly parallel that it needs to be to the spinous processes, and we're going to go back to the AP view. All right, now that our wings are fully deployed, we're going to put the right hand on the main channel here, and then the left hand is going to go on the white knob here. This is knob 2. We want to rotate this in a clockwise way because it's going to help move that hex nut forward. Picture? Perfect. Picture? All right, so now that our implant is fully deployed, we're going to come back to knob 1 here, rotating in a counterclockwise pattern to remove the instrumentation. So about 3 to 4 turns back here will allow us to remove the instrumentation. Picture? Perfect. And in one single stroke, we're going to take everything out. Picture? Excellent. All right, and then go back to the lateral view just for confirmation. So we've returned back to the lateral view for one final picture, and it shows complete and proper placement of the G5 implant. So we've just completed the posterior lateral arthrodesis procedure from Spinal Simplicity. This procedure is extremely impressive. For my patients, when I tell them that we're going to try to solve the problems that we've discussed and we've worked up for them using a lateral approach, their eyes light up. They're like, how are you going to put this in my spine laterally? And as we've demonstrated today, that not only is this possible, but this allows us to preserve a lot of the natural anatomy for this patient, like the multifidus and the interspinous ligament. And not only that, the recovery as a result of this approach is a lot less in duration. So thank you for joining me today.
All right, guys, so this is basically the end of our presentation tonight. I really want to thank for all the attendees for, hanging out with us. I know we ran a little bit over time, and especially for the faculty for sharing your wisdom tonight. One quick announcement here. So ASPN is accepting all the abstracts for our upcoming meeting in July, and the deadline is April 15th. And so you can just scan that QR code. And then on the behalf of Young Innovators, we're actually going to be holding our last webinar, which is going to be on the last Wednesday of June, right before our meeting. So we will be sending out more details in the next couple of weeks regarding that. But thank you guys for joining us tonight, and we look forward to seeing you in person soon. Thank you.